Welcome to the Health Trip Podcast. My name is Jill Foose. I'm a functional medicine and integrative nutrition health coach. I created this podcast to bring you along as we travel down intriguing, science-packed roads, debunking old medical paradigms and perusing new innovative therapies and modalities with the finest functional medicine doctors, practitioners, and like-minded biohackers while living our best life. Enjoy the show. Hi, everyone. Welcome to another episode of the Health Trip Podcast. Raise your hand if you're in menopause. You are not alone. You are in a club with about 75 million other women in the US, including myself. The average age of a woman in menopause is 51, but that can range between 40 and 58 years old. We are going to spend a third of our lives in menopause, so why not make it a beautiful time in our lives? There's just no need to suffer anymore during perimenopause, menopause, or postmenopause when we have options to support us. Perimenopause and menopause may include a variety of symptoms such as hot flashes, brain fog, low libido, anxiety, hair loss, and weight gain. Menopause also opens the door to an increased risk of chronic diseases such as cardiovascular disease, stroke, Alzheimer's, osteoporosis, and metabolic syndrome. I've said this before in previous podcasts, and I will say it again. At the end of the day, you get to make the final decision on whether or not to take hormone replacement therapy, whether it's HRT or BHRT. At the very least, educate yourself on the topic, the benefits, and the possible health consequences if you don't do anything. Then make your decision. My guest today is Dr. Wen Shen, an associate professor of clinical gynecology and an associate professor of oncology at the Oncology Center in the Johns Hopkins Medicine Department of Gynecology and Obstetrics. She is also the clinical director of the Menopause Consultation Service and co-director of the Women's Wellness and Healthy Aging Program. A board-certified gynecologist, Dr. Shen has concentrated on menopause medicine for more than 15 years. She specializes in treating perimenopause and menopausal symptoms, taking into consideration the woman's overall health. She often works with her patient's primary care provider to recommend non-hormonal therapies, alternative treatment options, and menopause hormone therapy as appropriate for the individual patient. She is a fellow of the American College of Obstetricians and Gynecologists and is on the board of trustees for the North American Menopause Society. She earned her master's in public health and her medical degree from Tulane University School of Medicine. She completed her residency in gynecology and obstetrics at the Johns Hopkins Hospital. So we are in good hands to talk about this topic once again. A little medical disclaimer before we dive in. By listening to this podcast, you agree not to use this podcast as medical advice or for the making of any lifestyle changes to treat any medical condition in either yourself or others. Consult your own physician for any medical issues that you may be having. This entire disclaimer also applies to any of my guests on my podcast. So sit back and open your minds and let's dig in with Dr. Wen Shen. Hi, Dr. Shen. Welcome to the Health Trip Podcast. I am so excited to bring you to my community today.
Thank you. Thank you for inviting me. I'm excited about this conversation also.
So I already did my opening about you, and I talked about a term that I'm not sure if you coined it or not, but it's menopause medicine. So where did that term come from, and what does it mean, and why are you so passionate about this?
So menopause medicine is something that is referred to, I don't know if I coined it, but is referred to quite often at the North American Menopause Society. It's a term that those of us who are part of that organization refer to because to us, menopause is more than just a woman not having any more periods, a woman having hot flashes. It is the whole woman and what happens to her during that menopause transition and what happens once she becomes post-menopausal.
Yeah, so why is this so passionate to you? I'm passionate about it because I'm in it. I'm almost 55 and I am in the throes of menopause. And so I'm always talking about how to get through this in a smooth way.
Right, exactly. I'm passionate about it because when a woman is going through the menopause transition and during the first few years after she stops having a period, she can have really, really significant, severe symptoms that severely affects her quality of life, which means her ability to concentrate, her ability to work, all the hot flashes during the day that interrupt her work and make her less effective, all the night sweats that wake her up and make her sleep deprived and fatigued and, brain fog and very irritable. Mood changes is a really, really big issue. Depression, anxiety. A lot of women can have experienced palpitations around perimenopause, and they're sent to a cardiologist who runs them through a battery of tests and tell them there's nothing wrong with them, go away, right? And so it's all of these symptoms that can be very scary and also cause a lot of frustration and despair for a lot of women. And so as a result, it's very important for me to be able to help women who are having these severe symptoms. But in addition, women, patients who come to see me usually will be kind of puzzled because I'll go through a whole list of questions about their past medical history, about their family history, about their lifestyles. And, they're kind of looking at me like, what does that have to do with my hot flash? And so to me, menopause medicine is a lot more than just a hot flash because she still has a third of her life to live. And what happens to her and how well she takes care of herself going forth from her menopause can really impact on how that last third of her life is lived.
And by the way, that last third of her life, because I'm just starting that third for myself, your kids are pretty much gone, right? They're off and running. They are out of the coop, and you get to now pivot your lifestyle and your desire in a direction that you want. You have a lot more time for yourself. So why not have it be the most vibrant, energetic, beautiful time in our lives?
Exactly. So you're very lucky that that is the case, but unfortunately, I do have a lot of patients who still have teenagers at home and have aging parents whom they have to be responsible for, and then they have a full-time job, and then there's a husband in the background who says, you don't love me anymore, we never have sex anymore, what's wrong? So that's just a lot on a woman.
Absolutely. So this is a good spot in the podcast to really break down what are these stages, because a lot of women are really unaware of when perimenopause starts, how long it can last, when menopause has taken action, and beyond. So let's break down the different stages for the listeners.
Right. So there is a lot of confusion with that. And a lot of patients are told, no, you're too young, you can't be in perimenopause. So really, a woman could start having perimenopausal symptoms in her 30s. Okay. But most women start having perimenopausal symptoms in their 40s. And perimenopausal symptoms are exactly what menopause symptoms are, right? The hot flashes, the night sweats, the mood swings. And so these can start in the 30s. And it's very discouraging to be told that you're too young, it's something else. But definitely, be aware if that is happening to you and it's persisting, then you are in perimenopause. And even if you're not having these distressing symptoms, if your periods start being irregular, okay, so you've always had regular periods, you can set the clock according to your periods, and then all of a sudden your periods are all over the place. That's another symptom that you are in perimenopause, okay? But because there are other things that can affect your menstrual cycle when you're in your 40s, it's very important for you to make sure that you are evaluated for your irregular periods, besides assuming that it's perimenopause. So that's, and usually with perimenopause, it can start 10 years before a woman's last menstrual period. So a woman won't know that the period she's having is her last menstrual period, right? Until she goes past that. And if she goes 12 consecutive months without a period, and that is a spontaneous 12 consecutive months, not because she's been on chemotherapy, not because she's had surgery. This is, her period just stopped for 12 consecutive months. Then she is considered post-menopausal. Okay, so once a woman is post-menopausal, it is when she will no longer have periods, when she is no longer reproductive. So that is when she can stop using her contraception. That is when but it doesn't mean that her symptoms will go away. So the menopause symptoms can continue for another 5 to 10 years. So there's a lot of years in there in which a woman can have all these symptoms. And
so wait, menopause is considered just really the 12 months then, the 12 months absent of a cycle. But what about spotting? A lot of women, including myself, have spotting. So do you have to start all over again when you spot?
Yeah. Especially if you, I know, it's very discouraging. Yeah, a lot of patients will say, I was ready to throw out my pots.
And I was so close.
Right, exactly. And then they have a couple more episodes, of spotting for a few months. And then, so yeah, the clock does start right over again because you're still having some ovarian function. It has not stopped yet. And because you're still having ovarian function, you also need to be aware that you need to be on contraception, because there is that possibility that you might ovulate during that time.
Right. Well, coming from a mother of 5 who are all gone now, I would never want that to happen.
Exactly.
Right. So when a woman goes through this, or when a woman is in menopause or even in perimenopause, they have some decisions to make, right? They have some decisions to make, which include taking hormone replacement therapy or bioidentical hormone replacement therapy. They can use alternative remedies and therapies, and they can do nothing. And some women breeze through menopause and don't have these symptoms. I didn't have too many of them. And we're going to talk about that because some people who choose not to do anything because they aren't having those symptoms. However, when you lift up the hood to menopause, there are some other factors to consider that are some serious health consequence of doing nothing, which we're going to talk about. But let's talk about these 3 options. Let's say a woman is going through menopause and she is in the school of, I want to do this naturally. I'm going to do Chinese herbs. I'm going to take this. I'm going to do acupuncture and shiatsu, and I'm going to breeze through. Are you in support of that? Is there, okay. Can you expand on what works, what is shown to work? And
exactly. So there have been clinical trials that show that acupuncture, mindfulness, and cognitive behavior therapy can help a woman go through her perimenopause and help lessen the menopausal symptoms that she's experiencing. Okay, so there is value to those practices. With regards to Chinese herbal medicine, there's some evidence-based data, but be very, very cognizant of the person you're going to and getting the herbs from, because there can be issues with contamination and issues with the herbs. And so there are people who are certified traditional Chinese medicine practitioners. And these people have to, show that their competency and that they understand what they're providing. And so they are much safer people from whom to get the Chinese herbal medicine.
Yeah.
And we do have such a practitioner at Hopkins that I refer patients to, and I feel very comfortable when he prescribes certain herbs for the patients.
Oh, I love that Johns Hopkins even has somebody there, right? Because you think of, I'm in Chicago, and you think of these big hospitals as being very much against that type of medical direction.
Right.
And, yeah.
Well, yeah, that was through very, very hard work on the part of Dr. Linda Lee, who brought integrative medicine to Hopkins, because, she had to fight pretty hard.
Yeah,
To
wonderful.
get it established.
So in 2009, you published a paper called the Treatment Strategies for Hot Flushes with Dr. Vered Stearns, who I just had on my podcast as well, who was the person that introduced me to you. And you found that estrogen use was the gold standard in terms of hot flashes.
Exactly.
So can you speak to a little bit about that?
Right. So the reason why a woman is having hot flashes is because her estrogen level has plummeted with menopause. And so it makes sense that if we treated her with estrogen, then that would resolve a lot of her hot flashes and improve it. And, scientifically speaking, we know that the thermoregulatory center in the brain has these neurons that have these receptors on them. And the receptors are estrogen receptors, and also a type of receptors that is focused on by KNDY neurotransmitters. Okay. And so, long story short, when a woman is premenopausal, her estrogen is predominating on these neurons, and her estrogen controls the effect that these neurons have on a woman's body temperature. But once she becomes postmenopausal and her estrogen level falls, the KNDY receptors go crazy, okay? And they get big and fat, and they stimulate what we call the vasodilation, the swelling of the blood vessels. That's why, you turn beet red and you start dripping sweat. And so that's what causes it. So if we are to replace the woman with estrogens again, that would, control these neurons again and get her thermal regulation back in order in her body. So that's the bottom line why estrogen is the gold standard, because that's the root of her having these hot flashes, right? But but a lot of women, for example, women with breast cancer who cannot use estrogen because they have an estrogen positive breast cancer. So that's how Dr. Stearns and I got to work so closely together, because, so many of her patients are referred to me because of their symptoms. And so estrogen is the gold standard, but there's more to the estrogen story, right? There is actually estrogen and progesterone receptors in every system in a woman's body, okay? Your brain is so rich in estrogen and progesterone receptors. Your heart, your lungs, your bones, not just your GYN organs. So as a result, there are a lot of changes that occur. And most of them, unfortunately, are detrimental changes that occur when the estrogen level decreases. And that is a big focus of my practice, is that, you know, we are living, as I said, in the last third of the life in postmenopause. And you want to be able to make it into your mid 80s vibrant, you know, active, okay, and happy, right? And unfortunately, along the way, you can be attacked by osteoporosis, which means that you break your hip when you step off the curb. And breaking a hip because of osteoporosis isn't just a matter of, you know, resting up and getting physical therapy for a few months. It means that, you know, 80% of women who have osteoporotic fractures cannot go back to their previous lifestyle, that they're in some way ambulatory, lessened, you know, some even to the point where they just can't even drive, they can't walk themselves. So, and then the next thing that's really important is heart disease. Women don't start having heart attacks until we're 65. And women go through menopause on the average at 51. And that's because of the effect of estrogen on the heart on a premenopausal woman is beneficial. And once she goes through menopause and that estrogen effect is taken away, then she starts building plaque in her blood vessels and her cardiac function decreases. And so at 65, more women have heart attacks than men. And heart disease is the primary killer of women, not breast cancer, not anything else, heart disease.
Right.
And then also cognitive, right? So I'm always about brain, bones, and heart, because I think these three things can markedly improve a woman's quality of life if we keep these things healthy. So you want to be able to be in the present. You want to have good cognitive function. And we also have evidence that estrogen helps with cognitive function. So, you know, that's my soapbox that I always get onto with my patients. And you know, patients can then decide what their risk factors are for these three diseases, okay? And what kind of trade-off, because a lot of women come to me, primarily the first thing they say they worry about is this going to cause breast cancer? Okay.
Right.
And so breast cancer compared to heart disease is very low on the list. Okay. So you can add all the top causes of mortality for women. The next 6 causes add up to equal mortality due to heart disease. So yes, breast cancer is something you want to keep in your mind. And it is something that's why you need to get your mammogram every single year after the age of 50. Okay. Especially if you're on hormone therapy. If you are going to go on hormone therapy, you've got to get your mammogram. Okay. And so, yes, it is something that we are very cognizant of, but if we diligently follow up and do all the screening that's necessary, okay, then hopefully the breast cancer can be detected at an early stage where it is, in today's oncology, is a treatable disease.
Right. Right. Wow, you really broke that down so well. I want to circle back to so many things actually, but I want to go back to osteoporosis first. So one of the things I suggest to my clients when I'm working with them is to get a DEXA scan. why wait till you're 65 when your health insurance is going to cover it when you're in your 50s? And let's capture a baseline of where you're at, because collecting more data helps you make better decisions for yourself. You can use the data or you can ignore the data, but the data is the data.
Right.
And so one of the things I talk about a lot is sarcopenia, which is the disease of the elderly.
Yep.
So this
Yep.
is loss of lean muscle mass.
Right.
So as we age and we're going through menopause, it is harder and harder to maintain lean muscle mass. And let's talk about the woman who never even exercised, and built that lean muscle mass to start with. And all of a sudden she's putting on a lot of midlife weight and she's not feeling very good. She's feeling sluggish. Her testosterone is dumping. All her hormone levels are crashing. And now we have to help her figure out how to pivot her lifestyle and get on board, because the way you live your life in your 20s and 30s ain't going to work for your 50s, 60s, 70s, and 80s.
Right. Right.
So what do you have to say about sarcopenia and how important? I know we're going to talk about lifestyle intervention, but let's just dump into diet and lifestyle right now with osteopenia. What are some things women should be aware of, and how serious is sarcopenia?
Right, right. So sarcopenia is a very under discussed aspect in menopause. We tend to focus so much on osteoporosis, right? That sarcopenia kind of is the stepsister of.
Right.
So let's start with what you said about DEXA scans. And you will be very happy to know that the physician who is the director of our metabolic bone center just gave us a very quick and dirty summary about her practice. And she also advocates for what you just said, okay, that you may have to pay out of pocket, okay, right. But if you really want to know, then you should get it. And there's usually a way to get your insurance company to pay for it, because almost every other woman who is not on vitamin D supplements is going to be low on her vitamin D level. Okay, so if you at some point had a blood test done that shows you are low on vitamin D or low on calcium, that's reason enough to get a DEXA scan paid for. Okay,
right.
So you can get a DEXA scan done before you're 65. And the thing we know is that the time during the perimenopause, even before menopause occurs, is when women are losing their bones the fastest. So if you get your bone density taken and it shows that you already have osteopenia, okay, and maybe you're not even done with your periods yet at that point, you're just perimenopausal, then you know that you need to start altering your lifestyle to improve, because as time goes on and you become postmenopausal, it's only going to get worse, right? So there are a lot of other indications. For example, if you've been on thyroid medication forever, if your mother has a history of osteoporotic fragility fracture, okay, if you've been on any sort of steroid treatment, people who have asthma and have been inhaling steroids all their lives, these are all reasons for getting a bone density done, because they could eat away. So, you might want to sit down with your primary provider and go through all of the medical issues, the family history, to see if there is a reason for getting a DEXA scan before 65. Okay, and that would make the head of the bone center very happy, because that's what she feels people should, women should do going into menopause. And then with regards to what you should do, weight-bearing exercise is like the
Yeah.
number one item on the list. And people immediately say, oh, but I don't want to go into a gym right now. And walking is such a good cardiovascular and weight-bearing exercise, because when you're walking, you're weight-bearing on all the major bones in your body, your legs, your hips, and your spine. So if you can do 30 to 45 minutes of walking 5 days a week, and as you get used to that walking, start ramping it up, start doing, cardiovascular walking, where you can carry small hand weights and really swing your arms to really get your heart going. So that simple act of walking can be good for your bones, your heart, and your brain. Okay. And I also, so there's a lot of discussion about vitamin D supplementation. And my recommendation is that I have not read of any evidence that taking vitamin D3 is detrimental in any way. Obviously, you don't want to overdose it, right? But definitely under 5,000 international units a day. And my usual recommendation is 2,000 international units of vitamin D3 a day is the recommended dose. And then also make sure that your diet is rich in calcium-rich foods. That's another place where, natural is better than the supplements. So Google foods that are high in calcium and incorporate it into your diet so that you're getting 1,200 milligrams of calcium a day. Now, obviously, if you have issues with your parathyroid, if you have had bariatric surgery for weight loss, if you have gut problems that cause you to not be able to absorb nutrients, then it's a whole different ballgame, right?
Right.
So then you need to comply with what your doctor tells you as the supplements that you need.
Right. I'd also like to add during this time that eating more protein is something to really focus on. I would say 95% of the women I work with are under eating protein. And that's detrimental because you can't go in and build lean muscle mass without eating protein. We need those amino acids.
Right. You need the protein to build those muscles. And in conjunction with the calcium, salmon and sardines are really wonderful lean protein and good on calcium.
Yep. So I want to also circle back to brain health, especially Alzheimer's. And we talked about, in terms of brain health, we talked about mood disorders. A lot of women become depressed or anxious, or they have fluctuations in their mood and they just feel very low. And a lot of women report that their OBGYN or their doctor prescribe antidepressants. And I get that this is a Band-Aid approach and not looking at the root cause. And so what are your thoughts on women who are taking antidepressants for this during menopause and completely not fixing the root cause here?
If taking the antidepressant actually resolves their mood symptoms, then I have less of an objection to it. But what I do see is a lot of women who do take these antidepressants and come to me and say that it hasn't really helped. Okay. And so because the estrogen in the brain, the lack of estrogen in the brain can cause problems with moods and anxiety, and especially, so there are psychiatrists who focus on menopausal health say that there are 3 times of vulnerability, and that's the word they use, of vulnerability for women. 1 is when she starts having her periods, 2 is when she's pregnant, and 3 is in menopause. And during these times, the crazy hormonal fluctuations really do affect your mood. Now, and I'm very careful about saying that because I don't want people to say, oh, she's just hormonal. Well, yeah, it is your hormones, but don't, negate it just because it is your hormones. It does a lot of harm, these hormonal. And so women who do have a history of postpartum depression, women who do have a history of, PMDD, PMS in their younger years are especially at risk for mood issues in menopause. And these mood issues could be quite severe to the point where, it affects their work. They're
debilitating.
Right. Exactly.
Absolutely.
It doesn't help to yell at your boss.
Right.
So,
Right.
So you want to be, and that's the thing. It's like the thing I hear all the time is, I am just not me.
So what is the conversation you have with a woman who comes to see you for support and she really doesn't want to go on hormones, whether it's HRT or BHRT, and she really wants to just tough this out? And you present her with all the information you just presented us with, all the symptoms, and then what's going on under the hood as well. What's that conversation like?
One thing I'm going to I want to talk about before I answer your question. Yep. I'm sorry for all these sidetracks.
No, this is great.
It's just I have all
the
these
more the merrier. We want to know.
So with regards to what you just said about hormones and BHRT, okay, that is a huge source of misunderstanding in the public right now. And bioidentical hormone replacement therapy is somewhat of a marketing gimmick, okay, and that people use in order to sell compounded, non-FDA approved and non-reimbursable hormone therapy, okay, that is an issue for me. I do object to that because a woman can very easily get FDA approved and insurance paid for hormone therapy that is literally exactly the same. Okay, so what do you think of when you say bioidentical hormones?
Well, I think of using a substance that is most identical to our natural substance that we produce. But you are correct that I buy my estradiol. I get it from Walgreens. It's covered under my insurance. I get my progesterone covered under it's micronized progesterone. It's covered under my insurance. The only one not available to women, though, is testosterone. And that's a big one.
Right. So there's a lot of effort going on to try and get testosterone approved by the FDA for women. It has been, and that's another thing, right? Why is it that Viagra is covered, but testosterone for women is not?
Right.
That's another soapbox for another day.
Right.
But anyway, okay. So
but wait, one more thing on that. A lot of women do come to me and they're using a combi patch, and the combi patch does have progestin, and there is a difference between progestin and progesterone.
Right.
So
with regards to what you just said, the estradiol patch, are you using the estradiol patch?
Yes.
Okay. The estradiol patch that you're using has 17 beta estradiol on it. 17 beta estradiol is the exact same molecule as the estradiol your ovaries used to make. How much more bioidentical can you get? It's the same molecule.
Right.
Okay. The only thing is, it is made in a laboratory by a pharmaceutical company, but it's still the same molecule.
Mm-hmm.
And it also is extracted from yams, Mexican
Mm-hmm.
wild yams.
Right.
And patients have asked me, well, then why can't I just eat the yams? Well, in order to eat enough yams to equal what is concentrated in your patch,
Mm-hmm.
you would be turning orange because of how much yams you're eating. Okay, you
Right.
just can't do it. Same thing with the natural progesterone that you're
Mm-hmm.
taking.
Yep.
Same exact molecule. So even though we don't use the term bioidentical,
Mm-hmm.
okay, they are in fact bioidentical. It's just that those of us who are, part of the menopause societies want to separate ourselves from um, hormone prescribers who may not be um, using evidence-based,
Mm-hmm.
okay? And compounding medications also can come with their risks, right? Because if the compounding is done under the right sterile conditions,
Mm-hmm.
everybody remembers those IVs that came from that compounding place up in Massachusetts that had all that that had fungal contamination and killed people. And so those are things that worry me about compounding. Um, there are a few FDA approved compounding
Mm-hmm.
pharmacies around, and I'm happy to send compounding prescriptions to those pharmacies because they
Yep.
have met with the FDA agreement and are certified.
Yep.
But there are a lot of fly-by-night compounding pharmacies.
I agree
that don't do
100%
that.
with you, especially in the world of peptide therapy right now. You see it online that you can get, this and that for
Yeah,
a quarter of the price, and you just
right.
don't want to go down that path. You need to be partnering up with a very educated and knowledgeable medical doctor who understands the ins and outs of this.
Where that exactly. And
Yeah.
so with regards to the combi patch,
Mm-hmm.
what you're saying is exactly true, that the progestin
Mm-hmm.
is part of that combination. And for a lot of patients, it's worth the convenience of just using a patch without
Mm-hmm.
having to do an oral dose of progesterone.
Mm-hmm.
So that's where that comes. Also, for some women, the natural progesterone capsule cannot adequately control spotting that occurs
Mm-hmm.
when they're on hormone therapy, whereas the progestins are stronger forms. And so the progestin and the combi patch may work better at controlling irregular spotting on hormone therapy.
Mm-hmm.
So the main reason, the number one reason why women are on progestogens after menopause is to help control the uterine lining. Estrogen stimulates the uterine lining and can result in uterine cancer if estrogen is used unopposed. Okay. And that's why if a woman has had a hysterectomy, then she can be on estrogen by itself. She doesn't really
Right.
need the progestogen. Okay. And so that's the primary reason. And then for me, I prescribe a lot of the natural progesterone, what you're using, because
Mm-hmm.
it also helps with sleep.
Right.
And sleep is a major issue for
Yep.
a lot of women.
Yep, absolutely.
Did I
Let's
answer your
talk.
questions?
Yes, yes. Great information. Let's talk about vaginal health and urinary incontinence, because that's something that a lot of women we don't want to talk about it, But they're two pretty adverse, ugly
Yep.
symptoms of this
Yep.
time in our life. Let's start
Yep.
with the urinary incontinence. This is, yeah, I remember the first time I experienced that when I was working out and my trainer had me do jumping jacks. And I was like, what the heck just happened? I just peed in my pants.
Yeah.
I told him we're never doing jumping jacks ever again. And I haven't since then. And that was years ago.
Yeah. Yeah.
So what's the connection between menopause and this?
A lot. So there is a new terminology, GSM, genital urinary syndrome of menopause. And it is a big, big topic. And as you said, it's something that women have traditionally not talked about because they were too embarrassed to, and especially back when most OBGYNs were men, they certainly didn't want to talk about it then. But it is one of my favorite subjects because there are so many things that I can offer a woman who is suffering from GSM. And so with regards to GSM, that's because we're back to estrogen, okay? Your estrogen level is low. And so all the estrogen receptors in your vagina, on the vulva, and in your bladder, okay? These are three areas that are very rich in estrogen receptors. And so if they're not getting their estrogen, they become very sad places. The skin, if we were to biopsy the skin goes from these thick, healthy, multi-layer down to one basal layer. And when we do the pelvic exam, very often we'll see these just really thin skin on the vulva that looks like if I even went anywhere near them with a speculum, they're going to start oozing and bleeding. And then in the vagina, the skin in the vagina becomes this pale white, non-stretchable skin. And so for a lot of my menopause patients, I'll tell them, you know what, let's talk about estrogen. Let's get you on some vaginal estrogen. And then you come back in 3 months and then I'll do your PAP. Because if I try to do a PAP now, you're not going to like me. So the estrogen that we use for GSM, very, very low dose. Okay. So low dose that if we were to draw blood 3 months after you've been using it, your estrogen level in your blood will still be post-menopausal. And the breast oncology people have agreed that their patients can use the vaginal estrogen treatments, okay? Because it is something that it's not just a matter of having sex. It is something that can be so symptomatic that just the everyday act of walking and sitting down, urinating, okay, when the urine hits the skin on the vulva can burn like fire. And then within the bladder itself, right, the bladder just cannot hold the volume of urine because the skin in the bladder also isn't stretching like it should. So with very small amounts of urine, you have the sensation that you have to go. So the most common type of incontinence that's estrogen related is what we call urge. Okay, the woman feels she has to use the bathroom much more frequently than she used to. And then she almost makes it to the toilet, not quite, and starts dribbling. Can be very, very annoying, right? What you've expressed, the jumping jacks and coughing, and that is usually associated with stress incontinence, right? Because you're causing stress to your bladder when you're jumping, when you're coughing. Those you would want to do Kegels exercises. You should do Kegels exercises,
right?
anyway, whether you have it or not. And the easiest way to do Kegel exercises is when you're sitting on the toilet and you're urinating. Squeeze your muscles down there and stop the stream. Hold it for as long as you can, let it go again. Hold it for as long as you can. Do as many of those repetitions as you can until you've totally emptied your bladder. So, you empty your bladder a few times a day, you'll get a few sets of that in. And the muscles down in your pelvis and around your bladder is just like muscles anywhere else on your body. If you exercise them, they get stronger. And there is evidence that shows women who do conscientiously practice Kegels have better bladder tone and control.
Oh, that's a great tip. Great tip. What about vaginal rejuvenation? What are your thoughts on that? Like the Viviv treatment. I think there's the Mona Lisa one. So I'm all for any way of biohacking, especially my sex life, right? Who doesn't want to have sex and have healthy and,
Absolutely.
non-painful intercourse?
Absolutely. And that is a really big thing. And so the laser treatment for the vagina was first started by Italian oncologists who have a lot of patients who could not use estrogen and were having severe vaginal genital urinary symptoms. And so what they noticed was that the dermatologists use these laser procedures to rejuvenate skin.
Mm-hmm.
And so they thought, why not vaginal skin? And so they put together, the vaginal laser probes, and they found a way of doing it. And so in a very, very small study with very few patients who were their breast cancer patients, they tested them and they found it to be effective in improving the symptoms. Okay. So, and the issue is that the study is their study was very small, and trying to get FDA to approve of the laser equipment here in the United States. FDA wanted more data. So there needs, and I know that the cancer people are trying to put together a national study of all the national medical centers for looking at the laser ablation procedure for breast cancer survivors, because obviously it's something that would be very beneficial for a lot of women. And what is shown is that, yes, it does seem to be effective, okay, but the beneficial effects tend to lessen after a year. Okay, so the usual treatment is 3 courses of the laser a month apart in the beginning, and then that will cause really good response. But it'll start wearing off after about a year, and you would need a touch-up in a year.
Right.
And so, and the second thing is that because it's not FDA approved, no insurance company is going to pay for it. So all of this is going to be out of pocket.
Very expensive.
And yeah, so it can be quite costly. And so there's still questions about the safety, because some women have received burns to it. And I have had a couple of patients who say that it didn't help them. So it's a lot of money out of pocket for something that didn't end up helping. But for the women for whom it did work, it was life-changing. Okay. And so it is something that is being performed by private OBGYNs who have the machine in their office. So, my recommendation would be to ask the OBGYN, how many have they done and what is their success rate?
Right.
And what is their a risk, like how many patients did have side effects.
Yep. Yep. So it is very expensive. I've actually done it a few times. The maintenance is about once a year. I haven't had it in a couple of years. I haven't had the need to have it, but there's also, so that's in an office and that's very expensive. But now there's a whole new generation of toys coming out from Femtech where you can have at-home red light laser therapy for your vagina. And I told my daughter, I have a red light therapy cap for my hair growth. I have a red light therapy box that I sit in front of for my mitochondrial health. I said, I could have a triple threat here and have one in my vagina all at the same time. She's like, oh my God, Mom, please don't post that. I could just light myself up with red light therapy.
Right.
Right.
And that's the other thing too, is like, for us menopausal women, we're not afraid to talk about these things.
Right.
The young women are mortified.
Yeah.
But, sense of humor goes a long way.
Absolutely.
And yeah, so with that, I looked that up and there isn't anything that's evidence-based. And so I can't really comment on it.
Yeah.
And I definitely can't comment on, safety,
right,
whatever.
Right. Still too new. But it brings me to a great question. You mentioned, these younger women most of us have daughters, right? And they're all in their 20s and 30s, maybe even older or teens. And they're, on birth control for good reason. What would you tell that younger woman about taking birth control or living a certain lifestyle to help set herself up for this time that is coming sooner than later? We all go through it. What are some words of wisdom?
So my words of wisdom is enjoy your youth, but be smart, right? Because definitely there are physical things that I wish I can still do that, arthritic old me is never going to do again. However, being smart means not taking risks with regards to sexually transmitted diseases, with lifestyles that means like smoking, drugs, alcohol, okay? Because that will impact you in the long run. So, and then with regards to birth control pills, I would say if it is something that does not cause side effects, that does not cause you to have blood pressure problems or have other side effects with breast discomfort, there are benefits to being on birth control pills. Number one, you won't get pregnant.
Correct.
Number two, the ovarian suppression, it's good data to show that women who are on birth control pill have lower risk of ovarian cancer. Okay, and that lower risk carries for 10 years after she's been on it. That you have lower risk of endometrial cancer. Okay, and also because of the estrogen, it helps support bone health. Okay, so there are young women who are prematurely postmenopausal who are on birth control pills for those reasons, to help with their hot flashes and also for their bone health. Okay, but just for the majority of young women who are using it for birth control, it also lowers your risk for being anemic, because most young women who are on birth control pills have much lighter bleeding, so that you're not going through boxes of tampons each period. And so there are a lot of beneficial effects, and there are a lot of different pills available too. That's the other thing.
Right.
Just because you've tried one type of pill and
Right.
you had issues with it, doesn't mean that it's all, because there are multiple different types of estrogens and progestins that are in different birth control pills. And so, you should be able to sit down with your gynecologist and review what kinds of symptoms and side effects you're experiencing and come up with one that would be better suited for you.
Yeah.
Mirena IUD is another great form of birth control pill if you're having bleeding problems and you need contraception. If you don't have bleeding problems, then the I shouldn't have used that commercial name, but anyway, non-hormonal IUD is also available. So they are very, very effective. But but they do not lower your risk for ovarian cancer for the other.
Right. Right. So are there any new treatment options for menopausal women coming down the pipeline?
Yes, really exciting. So what I was saying about those neurons
Yeah.
in the brain, the thermal so there are two major pharma that are in the process. One is further along for medication to treat to suppress the candy neurotransmitters so that they don't get all fat and happy and cause the hot flashes. So yeah,
Wow.
so I know it's really
Game
really
changer.
exciting. Yes, very much so. It won't confer the benefits that estrogen can confer. But on the other hand, a lot of the women who are cancer survivors and are just trying to make it through the day and through the night, that would be a huge game changer. Yeah.
Right.
So be ready for that.
Exciting.
FDA is definitely looking into it and hope
Fingers
to
crossed.
have that. Yeah. Yeah. And I'm also hoping one of them is the next step in their clinical trials is actually specifically looking at this treatment for cancer survivors. And so I'm really excited, and I'm definitely going to be part of that clinical trial because working with Dr. Stearns, I have so many breast cancer survivors who need that.
Right. Wonderful. So you're also the co-director of the Johns Hopkins Women's Wellness and Healthy Aging Program. That's along with Dr. Stearns, correct?
Right.
Yeah.
Right.
Can you share what that is all about and how women can contact you through there if they're looking for some more support?
Right. So we have a website, and I guess you have a way of putting up
I'll
the
list that.
Okay, so people can just look up the website, and there are links for contacting and also phone number to call. And what that program is all about is that it grew out of the collaboration that I have with Dr. Stearns, because medical care can be so complicated, and getting that appointment can be so complicated. And so we've had patients who was found to have osteoporosis, and I sent her to the metabolic bone clinic, and they are so flooded with patients that nobody can get an appointment. So our program is that we collaborate with a lot of these specialists who agree to reserve spots for patients that we refer. And obviously, patients that we refer are high risk patients. For example, after consulting a patient, I said, you are a heart attack waiting to happen. So I refer her to cardiology, and they know that if I'm referring her, it's because she needs to be seen sooner than later. And so that's what our program is all about. And, definitely, majority of the patients are sent to me because they're hot flashes and night sweats and mood swings, and vaginal symptoms are just intolerable. But we also look at the whole woman in a holistic way, and we provide integrated medicine for the patients.
Wonderful. I will absolutely list that website, and hopefully you'll be getting a swarm of calls after the new year.
Right.
So I always ask a question at the end of my podcast. I always ask my guests, what are 3 things that someone can do at home, right, to help whatever we're talking about? And so this question is, what are 3 things menopausal women can do at home right now without even seeing a doctor? And you already gave us a couple tips. One is, walking and getting that fresh air walk and really ramping it up with some weights. Another one was the Kegels, trying to stop the flow of urination while you're peeing. And is there any other tips that you can offer?
Mindfulness and cognitive behavior.
Love that.
Yeah. So they may not get rid of your hot flashes altogether, but they do help your peace of mind and your mood issues, and it's a myriad of benefits. And I'm finding more and more of my colleagues in other specialties are also referring patients for this, because in this day and age, right, we're all multitasking. There's so much anxiety in the world today. And so we all need to be able to center ourselves, and definitely the menopause symptoms aren't helping.
Right.
And so if you can just, take a few minutes to get inside your own head and calm yourself down, would be a huge, huge game changer, I think.
Yeah. One of the tips I offer my clients is when they wake up, before they grab their phone, have a notebook next to your bed and write down 3 things, 3 positive things. It could be about anything, your favorite food, that you like your hair, whatever it is to you. 3 things, that's it. And they have all found that to absolutely change the course of their day into a more positive direction. Just such a simple change. So it doesn't have to be signing up for a big yoga retreat, or, it doesn't have to cost you money. It's something that you can do at home, at your office. You just have to be mindful and make the time for it.
That's exactly right. And that's the same thing why I recommend walking too. It's, you don't have to spend money, and these are things you can do for yourself. And if the weather is bad, go to your local shopping mall before the mall opens.
Right. My mom does that.
Temperature controlled,
absolutely,
even floors to walk on.
Absolutely. Well, Dr. Shen, it was such an amazing podcast. You offered so much amazing information. My community is absolutely going to love all of this information. And I'll have to have you back. We'll talk more about women's health.
Okay, I'd love to. Just one more thing.
Yeah.
Please also post the menopause toolkit.
Yep, I have that in my notes as well.
Yeah, that is very helpful for evidence-based information for patients.
Wonderful. I will list everything, and thank you so much again. And I really appreciate your time.
My pleasure. Have good holidays.
Thank you. You as well.
Take care.
Thank you for joining me. I hope you enjoyed the podcast. Lifestyle changes can be hard and overwhelming to make. By building your support team of functional medicine doctors, therapists, and health coaches, you can reach your optimal health goals. Be sure to check out my other podcasts. Until we meet again, stay healthy.